Okay. And bonding is a very important process in composite fillings because it's the main thing that actually holds the composite to the tooth. So just to refresh, we know we have a filling that is um, amalgam, the metal filling that we're not using much anymore, still there. And we have the composite fillings that are the tooth colored material. So we'll get to know more about that. And we started with last group, with Wednesday group, with composite chair side. So we'll get to with each group to work chair side, and you're going to actually uh, be able to set up a tray and work chair side with me and assist in composite filling. So it make a lot of more sense as we start doing that next week or within this week to next week. But yeah, bonding process is a very important part, and understanding why we do that and what are the different parts of the bond and what are the different generations that we have is a good start to know the whole process. So I think we start with a video first of composite just to kind of get the main steps down to talk about how a composite filling is done in the first place. And then we'll talk afterwards with I'll get to the slides. Let me share my screen. And again, these videos, you guys have it all here. But let's see a composite filling. So one of the first parts, after we drill out the tooth, we would need to etch the tooth. And this, what you see here, the bluish material, is an acid etch. It's a phosphoric acid, usually about 37% phosphoric acid. And the main reason that we do the phosphoric acid is Wednesday group. If you remember anything from yesterday, to open up the dentinal tubules and the enamel rods, right? So remember when we talked about enamel and dentin, we said that dentin and enamel both have tubes in them. So dentin, we call them dentinal tubules. Enamel, we call them enamel rods. And this is just structure of the enamel and dentin. So the reasoning of the etching, or after we cut the tooth, usually as we prepared for a filling or a cavity, for a filling, we would actually close these blocked, and we need to open them back on to make sure that we were able to bond to them. And again, as we'll go further in the presentation, we'll know exactly what's happening. But that's the reason for the acid etch. It is to open up the dentinal tubules and the enamel rods. So we have to keep it there for about 20 to 30 seconds to actually do or frosty looking to it. That actually gives us an idea that this actually worked. If it didn't give us that frosty, chalky appearance, do it again. And again, we're going to look at the composite treatment procedure so we can talk a little bit further as we go in the slide and kind of relate to what we're. You need to remember that, or an easy. So A meaning the acid etch when we do the first step, and B bonding. And then C is cure or composite as well. So you have to put composite and then cure composite, okay? But ABC. So they're applying bond, which we're going to talk about our main subject for today. And bond is just, again, a glue-like material that would help to go into the dentinal tubules and enamel rods. And then, stick into the tooth or to the tooth. And then it will help us to have an area to get the composite to stick to it. Okay. Generally, it has a primer and adhesive. We'll talk about these parts about the bond. But again, it's kind of resin. So, and the composite is resin. So that will make it easier for composite to stick to the tooth. We usually dry it after we apply it just to remove the solvent that it has. And then we cure it, as you can see, with a curing light. This is a different type of matrices. You know, you guys are Toffelmeyers, right? Nowadays, there's a lot of times that they use these sectional matrices. We do have a kit in the lab if you want to see it. But nowadays, a lot of these, especially with composite fillings, because you don't need a lot of pressure. So you put that, you put a wedge, and then you put the rings to hold it up into place. It's a great system. It's a really nice system that you can use. This is the composite instrument. Again, I'm kind of trying to get you to relate to the things that we're going to talk about in the lab as well. This is a type of composite that is flowable. What classification is this? 2, right? Exactly. It's on posterior and interproximal. We put it, we cure it, and then we can build up the composite a little bit by a little bit. This is a packable type of composite. As you can see, we can pack it. It doesn't flow. Now the dentist is just recreating the anatomy of the tooth a little bit by a little bit. And again, definitely we match the shade of the tooth as much as possible because composite comes in different shades. We're trying to restore all of the anatomy, the pits and fissures, the cusps, as you can see, and even some discoloration sometimes that they put in here. That's the discoloration. We saw it last time with the composite filling as well, just again to make it look like natural teeth. They put a glycerin here. We'll talk about why later on when we talk about steps for the composite filling. And again, it's ABC, so acid, bonding, and then composite or curing. So bonding is the process that attach the restorative material to the tooth by adhesion, as we said, and again, that is mainly for composites. So when we want to prepare the tooth, one of the things that we need to think about after when we are doing any kind of filling that is a composite and we want to do coronal polishing, for example, we have to polish with a specific material, a prophy paste that we have, and that material called pumice. So the pumice doesn't contain any oils. It doesn't contain fluoride in it because the prophy paste that we're using now for coronal polishing, well, some of it, we do have actually pumice as well, but some of it has fluoride and have oils, and these will interfere with the process when we're trying to do a composite or sealants. So we want to avoid any prophy paste that contain oils that might interfere with the etch, with the bonding actually. Well, with the whole process. So just keep that in mind, and that will be more important as we start doing times when we're doing sealants, we're doing prophylaxis for the patient or coronal polishing for the child, and we have to make sure that we're not doing coronal polishing with a prophy paste that have oils. We have to do it with pumice. Okay. So after we prepare the tooth, again, doing that, we will have to etch, as we said. So this is the first step, like etch with it, which is the A step. And we said that we use what acid? Phosphoric acid, exactly. And the phosphoric acid, of course, of the tooth, which is technically the enamel and the dentinal tubules, exactly. by when we cut the tooth, as we're cutting the tooth to prepare dentin and enamel, we'll start blocking these dentinal tubules, form a layer on top of it, and again, this is what is called as phosphoric acid. It will dissolve this smear layer and open the dentinal tubules and enamel rods. So this is again what we're talking about. You can see these are the dentinal tubules, enamel rods of under the electronic microscope. You can see this is the actual dentinal tubule. You see it's a tube that is in the dentin, and this is the smear layer that goes into it when we cut and prepare the tooth. And you can see it blocks it, so we cannot actually, I mean, the dentin is now completely blocked and closed. And what we want to do again to remove that smear layer with the acid, and then this would allow the bond to go through into the dentin, be able to stick to it, and then so that our composite will get attached to it. More about etching. So when we etch enamel, let me see, do we have any pictures here? This is usually how etch comes in, small syringes. When we etch enamel, a small portion opens the pores. Our timing is usually, well, 15 to 30 seconds, but anyway, 20 to 30. Usually the time is 30 seconds of etch. Get all of the pores open and all of the smear layer removed. The enamel, when we etch it for the correct, as chalky and frosty, right? That's how you want to see it. Etch can come in liquid or gel. Usually they colored it so we can see where we're putting it on. And then we want to rinse for same amount of time that we're etching to make sure we're removing all of that acid. As we'll do in the lab, we definitely have to isolate the tooth so that the patient will not, we don't have any of that acid etch going into the patient and any of the saliva contamination. And we have to rinse it. We have to get the HVE and, get it really close to the tooth and make sure it goes into the HVE instead of the tissue mouth. Again, we'll do that and I don't think most probably. That's a good question. um, yeah, I'm thinking. I need to go and look it up. Thing that comes to mind specifically. Yeah, I need to look that up. But I guess we. Let me see. Their enamel is even thinner. They don't have a thicker enamel. We'll look it up and check for the exact answer. Yeah, I don't have an actual answer. Etching. It is recommended nowadays. What we are doing, a lot of dentists are doing selective etching, in which they would actually only etch the enamel instead of the dentin end. And if you're going to etch dentin, then you will actually do a less etching time because the dentin has more organic material, so it's more watery. And if we actually over etched it, we'll break the structure that it has, and it can actually lead to a weakened bond and even more sensitivity. So a lot of times now dentists use what we call selective etching, which again just, we'll talk about it in a little bit afterwards. It's just etching the enamel, not etching etching for dentin. So you have about 10 seconds etching dentin and 30 seconds etching enamel. Again, this is what the dentist would do, but just to understand the process, we do etch, we do use that when we're doing sealants. So that's part of our process as well, but we don't do etching on dentin. I mean, that's what the dentist would do. So this is technically, this is what you see here. That's the selective etching where we don't etch dentin. This is if we etch both of them. And then we have a bonding type that actually does the etching by itself, where we do not need any acid, which we'll talk about again in a little bit. So it can weaken the bond and it can actually have more sensitivity. And we'll rinse it. The organic material and it open up. So they would like to say it will appear fluffy more. If it's completely dry, it will not bond to it as much when we do the bonding. Keep that a little bit wet. I have a picture like that here. This is like, that's a dentin that we rinsed. After we rinse the acid etch to the bonding to the dentin. Enamel bonding are strong. Again, it has less organic material, so it bonds much easier. We want it to be dry, and we can just wet it completely with the bonding, and it will make it a stronger bonding process. Any contaminants definitely would lower the strength. So if we have any saliva, any blood parts, that's why we have to make sure that we are completely, surround the teeth or do moisture control with rubber dam and gun rolls, if not rubber dam. And then the dentin bonding, it's a little bit weaker than that, but it's a little bit, again, more complicated because of the dentin structure. And that's why we want to keep a little bit more wet dentin. And this, keeping the dentin moist, that will actually make better bonding. Okay. So let's take a look at this video that we have in here. Hopefully we're still all good. Okay. This is a nice explanation. As I said, the general process is ABC, right? We acid etch, we do the bonding, and then we do the composite. The newer systems that we have of bonding, so bonding has generations, as we'll talk about in a little bit. The newer generations would not require any acid etch. So they will do etch, which we call a self-etch bond, which you'll see here in this video. It's a really nice one because, again, we can see the dentinal tubules, how they open, and how this relates to post-operative sensitivity, which is a big problem. So a lot of times when they talk about doing, about sensitivity in the teeth, it's all too dentin. Because if you etch too much and too harsh, you can open these dentinal tubules and it can affect them. So let's see this video. Let me see. I don't know why the sound is not. Should be on. I might have done something through here. Oh no. see. Oh, I know why. Okay.
With the MDP monomer component, one significant invention is self-etching technology, with the MDP monomer combining two functions, etching and bonding. Carrara's self-etching primer, which includes the MDP monomer, etches mildly, thus reducing the risk of post-operative. To show the characteristics of Carrara's high bond performance, a posterior restoration was chosen. After the removal of caries, the tube structure is covered by a smear layer. With self-etching technology, the primer itself is applied with acidic properties and applied to the tube without phosphoric acid.
So we're not putting any etch.
Thanks to the mild etching process, the dentinal tubules are still protected by the smear plug. Hence, movement of dentinal fluid inside the tubules. This effect when it comes to minimizing post-operative sensitivity. Crystals in the collagen fiber network. Self-etching process decalcifies hydroxy. Thanks to the mildness of the etching agent, many hydroxyapatite crystals remain in the collagen network, thus preventing hydrolysis. The etch and rinse system uses phosphoric acid to prepare. Layer is dissolved. One disadvantage is the harshness of the etching process. Compared to Carrara's self-etching systems, phosphoric acid is much more aggressive. Furthermore, the harsh phosphoric acid also dissolves the smear plug. Hence, the dentinal tubules are opened, creating the risk of postoperative sensitivity. When comparing images, the difference between aggressive etch and rinse systems and Carrara's self-etching system becomes evident.
And that's again the reason why if we're doing etch anyway to Dentin, etch it less amount of time than operative sensitivity would not happen, and we do not actually remove all of the plug, the dentin.
Postoperative sensitivity caused by movement of dentinal fluid in cases of occlusal stress. Another disadvantage of the harsh etching process concerns the collagen fiber network. The aggressive phosphoric acid dissolves most hydroxyapatite in the collagen network, leaving a zone of exposed collagen fibers susceptible to hydrolysis. Hardly any protection exists for collagen fiber. Etch and rinse systems have a high risk of hydrolysis of collagen fiber compared to self-etching systems. The main benefits of Carrara's self-etching technology are minimal risk of postoperative sensitivity, strong chemical bond, hence excellent sealing properties, and a low risk of secondary caries. And, as a result, long-lasting restorations.
And again, at the end of the day, it's dentist preference and their, you know, experience with different companies and different products out there. That will actually make the choice at the end of the day. So you open them exactly. Yeah, just because you saw, what we at the Dentin, we have a fluid technique. Actually, that's how there are theories about how we these are completely open and not protected anymore. So the self-etching or not completely removing that smear, just gives us a little bit, gives the patient a little bit less postoperative pain. Yes. Yeah, it doesn't like make sense, how it will go and actually, feel, but that's how it works. I mean, at the end of the day, that occlusal load will actually go and affect. There will be some pressure in there, and we're really sensitive in our team, and that's a problem that patient has. That's an issue that happens. So, oh, when did he have it? When did he have it? How long? Like a month ago or 2 months ago? Yeah, I mean, if it's still there, go back and check. If it's too, usually it reduces. The pain, the postoperative pain usually goes a little bit by a little bit. It reduces with time a little bit. It's regular to have postoperative pain right after, but at with time, usually it just start to reduce a little bit by a little bit. So if you still feel some pain, then you might need to go back and check. Yeah, and postoperative sensitivity is not just because of that. Like some of these, the really nice lectures that sometimes in these meetings. So he was talking about like even the burr that we use. People reuse burrs all the time, the burrs that we have for high speed and low speed. But if you reuse it, they must probably, especially if it's not made for reused, be more blunt. That means when you cut, you'll produce more heat, and when you produce more heat, it will affect the dentin and the pulp, and this can cause postoperative activity. So there are multiple things that actually affect that, and it's just these small, tiny things that nobody think about. Again, patients, we never think about, the small parts and dentistry and the filling that actually really affects our filling quality. But once you start getting into the field and understanding how important and different one product to the other, you can see how each step can really affect the filling and the longevity and the success of the work. It's not just how much the dentist is good at their work of removing the filling or making it look pretty. It's just so materials that we use and how important they are for our work. So, and again, I mean, these can be really expensive. The bonding systems and the different parts, and some things take you longer to do. But again, the patient would not really recognize these things unless like we explain a few of that to them. Okay. So what are bonding agents? They are resin that are dissolved in solvents. They are flow into porosities that are created by the etch, right? By etching when we do the etching. So it is technically the bond by itself is made by a primer and adhesive. So before again, like older versions of bonding, they come, and I mean, it's still sold nowadays, and some dentists might prefer it. They come actually in two bottles. Instead of just having a bond bottle, you can actually have a primer and then an adhesive. And the primer technically is the part that goes into the dentinal tubules, and then the adhesive bonds to the primer and bonds to the composite on the other side. So what they did now, again, with the most new ones, they put the primer and the adhesive together in one bottle, and then again with the self etch, They have the primer, the adhesive, and the etching one, where you don't have to etch, you don't have to prime, you one step, and you get everything done. So see, like for example, this, let me see. This is when we're chair side. Do not leave bond exposed to air. So whenever you open the bond bottle, make sure you recap it right away. And if you put a drop of it, make sure you want to cover it, as again we'll do in chair side. So the self-etching technique is what we just watched a video on, a system that does not use or do not use phosphoric acid etching. Instead, it has a primer that etch, for you in the same step. So you will not etch and rinse. You'll just apply bonding, which is a self-etching. You cure, and you're good to go. The regular process, but again, it just depends on the dentist preference and use. So again, we have, and it can be separate bottles, so primer by itself, and you know that has the primer and adhesive together. So they said this. We're now in generation 8, which is technically the universal bonding systems. But let's go back and talk about 4 and 5, because these are more relevant nowadays. The 1 to 3 are not used anymore. So this method, or this generation 4 and 5, we call it an all etch or total etch. So technically you etch and rinse. So you etch the enamel, you etch the dentin with phosphoric acid, and then you do the bonding. So you etch and rinse, and then you bond afterwards. And this is the generation. The self-etch does not require the use of phosphoric acid that we washed, and it has the etching agent into it, and it use. Sometimes we do the selective etching of enamel with this. And selective etching is just etching the enamel, not the bond. Okay? Because usually you have to etch bond and enamel together. But with the self-etching bond, we can just etch enamel for the process. And again, the selective etching is this, what you see here. That's the selective etch. Just the enamel. And then universal system bond, we can use total etching with it or selective etching. Okay. And again, bond can come in different shapes. It can come in bottles that we use, put on a what we call a mixing well, and then we use it with a micro brush, or it can come in these single units. Something similar to that is just a one unit where you can use it for one patient instead of having to have like a bottle that you use for different patients. And there's even this pen, bond pen, that you can just change the tip and use instead of having to put that in a um, mixing well and use it. We have another type also that comes in these. Also, these are single-use units that you can just use for. As the single-use. Okay, we have definitely to cure the bond um, to make it work actually. So we have self-cure, where it will actually chemically cure by itself. Uh, we have light cure, and sometimes there's a dual. So, but most bonds that we use, actually, you need to cure them with light. With we cure them usually. Uh, Sometimes it goes into the skin, and you can mine everything with saliva, less bonding strength. And then postoperative sensitivity, as we said, and on the system that you're using, or sometimes less. Sure hurts, right? Right. So remember, mainly bonds are made of and adhesive, right? That's what they're made of. And the third step is etching, or we etch and then we prime and we adhere to the adhesive. So this will go just general. You have etch, you have primer, you have now the etch, obviously we know constitutes parts of the tooth structure. We're removing minerals from the tooth or inorganic components. And so in the enamel, we're removing hydroxyapatite. In the dentin, we're also removing hydroxyapatite, and we're leaving collagen fibers in the dentin. Now, the primer contains a solvent and it contains a monomer. The solvent carries the monomer into the tooth, into these micromechanical areas that we created with the etch, and it also serves as a way to attach the adhesive to the tooth as well. That's what the monomer does. Now, the adhesive component contains a lot of different things. The easiest way to look at this is it's very similar to like a flowable composite. Typically, it has a component that will allow it to set or to cure within those micromechanical areas we've created with the etch. So that's pretty much in a nutshell the way you should look at these bonding agents. As an etch, a primer, and as an adhesive. Now let's look at what types of bonding agents are available. Right now, we have currently generations 4th through 7th generation bonding agents available to us. Generations 1 through 3, we don't use those anymore, they're more historical. All right, so if you look at the 4th generation, which is also referred to as a 3-step etch and rinse bonding agent. Etch and rinse because you're applying a separate phosphoric acid etch to the tooth and rinsing that off prior to applying the primer and the adhesive. Now, if we look at this, one of the best examples of a 4th generation 3-step etch and rinse bonding agent is OptiBond FL. So we have a separate etch, we have a separate primer, and we have a separate adhesive. Now, let's look at a 5th generation 2-step etch and rinse. For that specific type of bonding agent, we have two things that are combined. The primer and the adhesive are combined into one bottle, and you still have a separate etch. So we have the etch component, and within this specific little capsule here, we have the primer and the adhesive combined together. This specific product is OptiBond Solo Plus, which is that 2-step etch and rinse. Let's take a look at a 6th generation self-etch bonding agent, specifically a 2-step self-etch bonding agent. Now, it's 2 steps because instead of the primer and adhesive being combined together, there's a 2-step self-etch bonding agent. The etch and the primer are combined together. The best example of this that I know is Clearfill SE. Now, in Clearfill SE, you have the self-etching primer, which is your etch and primer together in one bottle, and you have the separate adhesive component. It's just mixing these together in a different way. Separate. Now let's look at a 7th generation 1-step self-etching bonding agent. Now you can imagine all these different types of bonding
combinations of etch, primer, and adhesive. So the seventh generation is going to be the etch, the primer, and the adhesive all in one bottle. And that's what we have here with Scotch Bond Universal. Everything is in this one bottle, and you can apply it as such. Now keep in mind, many of these products, especially the self-etching Dentin bonding agents, does give you an option to apply a separate phosphoric acid etch. Obviously.
Anyway, again, just to see that, and I want just to show you this to see the new.
Hello, my name is Dr. Leanne, and in this video, I'm going to walk you through the step-by-step procedure for using Adhesive Universal in the Beaver pen.
Now that's kind of the newer way of applying bond. It just comes in a pen instead of having to put in a bottle.
To be used in indirect utilizing the total etch, self-etch, or selective etch technique. It's available in this unique Beaver pen. Bonding process. Applying adhesive with the Beaver pen is fast and easy.
Yeah, it's just a different way of doing things. Okay, and we have other ones if you guys want to watch later on. Let's could not find any device. That's okay.